Dr. Bien Matawaran is the Chief of the Section of Endocrinology, Diabetes, and Metabolism of the University of Santo Tomas Hospital. She is part of the academe as well, being the chairman and an associate professor of the Section of Biochemistry and Molecular Biology and Nutrition of the University of Santo Tomas Faculty of Medicine and Surgery. He was the past president of the Philippine Society of Endocrinology, Diabetes, and Metabolism, and also the past chairman of the Department of Internal Medicine of Jose Reyes Memorial Medical Center. So again, let's all welcome Dr. Bien Matawaran. Mabuhay, Professor Matawaran. The virtual stage is yours.
Thank you very much for that generous introduction and welcome to this virtual symposium. So my talk for today is about diabetes and how we manage our patients with diabetes. And this is in the light of the many CV outcome trials that were quite familiar from the past several years. As you can see in this particular slide, you see several CV outcome trials for the newer medications for diabetes. So that would include your DPP-4 inhibitors, the SGLT2 inhibitors, the GLP-1 receptor agonist that has been has come to the forefront, no? Especially because of the robust outcomes with regards to reductions in CV events. And because of this, we've heard about a paradigm shift with regards to the management of type 2 diabetes. For the question for today is really how big is the shift in daily practice? We now have to look back, step back and look at our patients and find out how different should our management be in the light of the CV outcome trials. So I would like to illustrate my point now using two cases. So we have here a case of a 43-year-old bank teller with polyuria, polydipsia, and polyphagia, all signs of hyperglycemia, diagnosed diabetic for about 3 years on metformin at 1 gram daily. And if you look at her laboratory parameters, her FBS and HbA1c are both not controlled. How about our case 2? So we have a 49-year-old male lawyer, also with symptoms of hyperglycemia, have been diabetic for more than 5 years, maintained on gliclazide, a sulfonylurea, and a biguanide, metformin at 1 gram daily. At 2 grams daily. What is different for case number 2 is that he has established cardiovascular disease. He underwent angioplasty and is maintained on several agents as part of standard of care for patients with coronary artery disease. And like our first case, you see that his FBS and HbA1c are also not a target. So with that two cases, let me go through the relevance of a time-tested and evidence-based drug in the modern management of type 2 diabetes. As we said, has there been really a big shift with regards to management of our patients with diabetes? So these are my disclosures. And our objectives for this afternoon is to discuss the important treatment characteristics to achieve good glycemic control. We will also try to review the trials addressing the role of glycemic control in reducing micro and macrovascular complications of diabetes. We'll go through some of the RCTs, the randomized controlled trials, the cardiovascular outcome trials, and real-world evidence. And lastly, we'll describe the use of sulfonylureas in the prevention of type 2 diabetes complications based on recent management guidelines. Based on the DCCT and the UKPDS, we are well aware that the risk of complications increase with poorer glycemic control. So based on these two trials for type 1 diabetes and for type 2 diabetes, that is the DCCT and the UKPDS respectively, we see that the relative risk for complications increase with increased HbA1c, and that any intervention that will eventually lower HbA1c, we also see a reflection in the reduction of these complications. And this is why, from the past few years, we have recommendations telling us on how to manage hyperglycemia in patients with type 2 diabetes. And the parameters to lower blood sugar in patients with hyperglycemia is based on several key characteristics with regards to the pharmaceutical agents that would be used. One, is that this agent should be efficacious in lowering HbA1c. 2 is that this agent should have a good hypoglycemia risk. 3 is that they are at best weight neutral or can induce weight loss for patients with diabetes that are obese and have minimal side effects. And of course, they are inexpensive or less costly. Ideally, this intervention should eventually help you achieve glycemia after 3 months of treatment. So that choosing anti-hyperglycemic therapy is based on what you call the benefit and risk ratio. So we choose agents that are beneficial with less harm. And this is why we have to go through all of the parameters that I mentioned earlier. So for efficacy, we are well aware of the different agents for type 2 diabetes and their relative effect with regards to reduction in HbA1c. In this pooled analysis of different trial, you will see that metformin and sulfonylurea are potent agents for HbA1c reduction. Though taken as monotherapy and in combination, we see thresholds in its ability to lower HbA1c, unlike, of course, your insulin. In a more recent trial published in 2018, we have a study looking at the effectiveness of gliclazide MR, 60 milligrams in the management of type 2 diabetes. This is an observational study to analyze titration of diamicron MR, or what we call the EC-DIET trial. So this particular trial aims to evaluate the effectiveness of gliclazide MR 60 milligrams in individuals with type 2 diabetes in a broad range of diabetes history, body mass index, and background anti-hyperglycemic treatment. So this study enrolled more than 7,000 participants from 8 countries aged 35 years old and above with HbA1cs of more than 7.5%, not on insulin. So they were given and titrated 30 to 120 milligrams of gliclazide MR once daily, and HbA1c goals were individualized and dosing up titrated as required over the 6-month-long period. Efficacy endpoints included baseline HbA1c changes, weight, and of course, the glucose-lowering agents. And of course, as part of the safety outcomes, episodes of hyperglycemia requiring assistance were documented. As you can see, the EC-DIET study participants enrolled patients, around 90% of patients with BMI of more than 25 and with baseline HbA1c of more than 8% to almost 80+% of total patient population. So it shows us that those patients in the EC-DIET trial have poor glycemic control. As we go through the temporal and those associated improvements in HbA1c, we see in this particular graph, at baseline, you see that the baseline HbA1c of these patients are between 8.3 to 9.2%, given the gliclazide at up-titrated doses of 30, 60, 90, and 120 milligrams, and the eventual reduction in HbA1c at 3 months and 6 months after. As you can see, very significant that almost all of those patients that were up-titrated with gliclazide showed reductions in HbA1c and were able to reach a target HbA1c of 7.5% and below. So the clinically significant HbA1c improvements were noted across all baseline HbA1c strata. As you can see, those patients with baseline HbA1c of 7 to 8%, up to those patients with HbA1c of more than 10%, showed significant HbA1c improvement, more so for those patients with higher HbA1c of more than 10%. Similarly, there were also clinically significant HbA1c improvement were noted across BMI classifications for those with BMI of less than 25, as well as for those patients with BMI of more than 30. And there were significant improvements likewise, regardless of the original diabetes treatment regimen. For those who were newly diagnosed or treatment naive, as add-on to metformin, for those who were switched from an SU, and those who were switched from a DPP-4 inhibitor. So the EC-DIET trial showed us the efficacy of glycoside MR or diamicron MR. It showed that progressive glycoside MR at 60 milligram up titration was well tolerated and lowered HbA1c across a broad range of HbA1c, BMI, and background glucose lowering therapy. So that shows efficacy. How about hypoglycemia? We all know the very good hypoglycemia profile of glycoside, especially compared to other SUs. If you look at this particular table relating the relative rates of hypoglycemia with glycoside and all the other SUs, you see that the episodes of severe hypoglycemia is considerably less per person years in those patients started on glycoside versus other SUs. In a meta-analysis of patients who were fasting during Ramadan, you will see that glycoside and DPP-4 inhibitors have similarly low risk of symptomatic hypoglycemia for those patients celebrating the Ramadan. As you can see in this forest plot and at the point estimate that touches the line of nullity, you see that there's no difference in the risk of symptomatic hypoglycemia when we compare patients on glycoside versus those patients on DPP-4 inhibitor. In addition to that, April of 2020, the DIA-Ramadan real-world study in patients with type 2 diabetes mellitus treated with glycoside modified release during fasting also solidified the safety and effectiveness of diamicron MR. In the DIA-Ramadan trial, whereby more than 1,000 adults with type 2 diabetes controlled or suboptimal controlled with glycoside MR were followed up during Ramadan, and patients were asked to continue concomitant treatments for diabetes, hypertension, and dyslipidemia. The primary outcome of the DIA-Ramadan study included the number of symptomatic hypoglycemic events and also measured secondary outcomes, which included changes in HbA1c, fasting plasma glucose, and weight between visit 0 and visit 1. So this is basically the study design of the DIA-Ramadan Prospective International Observational Study. As you can see, patients treated with glycoside MR for at least 90 days, no work included in the study. Okay, so at visit 0, and then pre-Ramadan celebration, they were characterized, as well as during Ramadan and after Ramadan, 4 to 6 weeks after. So the primary endpoint, as I've mentioned, is proportion of patients reporting one symptomatic hypoglycemic episode, and the secondary endpoints included changes in these parameters. So these were the baseline anti-diabetic treatment in the DIA-Ramadan study. As you can see, almost 50% or 41% exactly were on glycoside MR alone. 27% were on dual combination with metformin, while others were on combination of DPP-4 inhibitors as well as SGLT2 inhibitors, and even in combination with GLP-1 receptor agonists. If you look at the primary outcomes, and that is the proportion of patients reporting one symptomatic hypoglycemic event, you will see that during Ramadan, the episodes of hypoglycemia in those patients receiving glycoside were low or not as severe. Okay, so during Ramadan, pre-Ramadan, and post-Ramadan. There was also significant reduction in HbA1c and fasting plasma glucose. If you look at visit 0 and visit 1, you see a significant drop in HbA1c, as well as significant drop from visit 0 to visit 1 with regards to fasting plasma glucose. There was also a significant reduction in body weight and body mass comparing visit 0 and visit 1 in the cohort of patients that were included in the DIA-Ramadan study. How about cost? We said that cost is very important with regards to choosing an anti-hyperglycemic agent. So in this particular study by the WHO, you see here the proportion of households with participants with known diabetes who might not be able to afford anti-diabetic medications. So it shows us how important cost is with regards to our choices of anti-diabetic regimen. In this analysis, whereby different countries were analyzed, so high-income countries, upper middle-income countries, lower middle-income countries, low-income countries, and India, they tried to identify the proportion of households that can afford these different anti-diabetic medications. So these included metformin, glycoside, libenclamide, and insulin. In the Philippines, which is included in the lower middle-income countries, you will see that, again, a significant number of patients cannot afford, or a significant number of households cannot afford even metformin, glycoside, and glibenclamide. So that tells you that for countries like the Philippines, cost should also be an issue. And this is why the WHO came up with a recommendation for medicines for treatment intensification in type 2 diabetes and type 1 diabetes in low resource setting. So this recommendation is particularly for those countries of low resource setting or those countries of high income countries, however, with disadvantaged population. And in this recommendation, it says that sulfonylurea should be given to patients with type 2 diabetes who do not achieve glycemic control with metformin alone. And even recommending the use of human insulin as part of the third-line treatment for those uncontrolled on sulfonylurea and metformin with DPP-4 inhibitor and SGLT inhibitor, as well as thiazolidinediones as part of the next tier of treatment, mainly because, again, of issues of affordability. So that if you now look at those important characteristics in choosing your anti-diabetic agent, HbA1c, weight, and hypoglycemia, you will see that glycoside, especially compared to other sulfonylureas in purple, would have a very good profile with regards to HbA1c reduction, weight gain, and hypoglycemia profile. So with those characteristics, it is now very important that we learn the newer recommendations, because those characteristics are important, as we've said. However, it is now in the new recommendation that we think of or identify first as more important patient phenotype, meaning we have to identify more comorbidities of patients when choosing our anti-diabetic agents. And this is where the trials with regards to the role of glycemic control is important with regards to these recommendations. Based on a retrospective study looking at patients with diabetes with previous acute MI, as well as those patients without previous MI, looking at reduction of acute myocardial infarction. In this retrospective analysis in Sweden, it noted that patients need to control their glycosylated hemoglobin, systolic blood pressure, and LDL cholesterol as factors that will eventually predict occurrence of acute MI. Similarly, glycated hemoglobin also is an important risk factor for predicting stroke in those patients with and without previous stroke. So it shows us that really in this retrospective analysis, glycosylated hemoglobin is also important, or is still very important. However, we are well aware of different intensive glycemic control trials, mainly used to identify reductions in both microvascular and more so cardiovascular disease in patients with type 2 diabetes. And these intensive glycemic control trials, of course, include your UKPDS, your ACCORD trial, ADVANCE, and the VADT. The UGDP, or University Group Diabetes program, is an initial trial in 1970s. However, turned out to be with excess of mortality for those patients given older sulfonylurea or your tolbutamide. So we'll go through this intensive glycemic control trial. We have to remember that these large diabetes clinical trials have different patient population. Particularly, the UKPDS enrolled patients were newly diagnosed diabetic, while the ADVANCE, the ACCORD, and the VADT enrolled patients with chronic diabetes mellitus. Also, history of cardiovascular disease is well pronounced in those patients in the ACCORD, in the ADVANCE, and the VADT. So again, this trial design is to compare the effects of achieving lower HbA1cs. As you can see, this particular table, you will see the differences at the end of the trial with regards to the HbA1cs achieved in the ACCORD, in the ADVANCE, in the VADT, as well as in the UKPDS. Because of this study, particularly the UKPDS, we've learned that any reduction in HbA1c, particularly a 0.9% reduction in the original UKPDS, translated to a 12% reduction in any diabetes-related endpoint, a 25% reduction in microvascular disease, and a 16% myocardial infarction reduction, though this did not turn out to be statistically significant. However, after 10 years of the UKPDS, we've learned likewise the persistent reduction in outcomes, especially the reduction in macrovascular complication, and that is myocardial infarction. And we've noted that this eventual significant reduction in MI is what we now call the legacy effect. So this showed that in type 2 diabetes, improvements in glycemic control reduce the risk of complications, especially for the newly diagnosed type 2 diabetics in the UKPDS. So that the implications of tight glycemic control showed that with HbA1c reduction, you see a reduction in microvascular complications, though the ACCORD, the ADVANCE, and the VADT did not show a significant reduction in cardiovascular disease or macrovascular complications. And we have to take note that in the follow-up trial in the UKPDS, we did saw the eventual reduction in macrovascular complications as well as in mortality. Of note is the excess in mortality in the ACCORD trial. If you look at the pooled relative risk and risk difference estimates in CV mortality and all-cause mortality in the 4 trials, you will see that in the ACCORD, there was a relatively higher risk for cardiovascular disease mortality as well as in all-cause mortality. And if you compare that to ADVANCE, it was only in ADVANCE, okay, versus that of ACCORD and VADT that showed a trend in reduction in cardiovascular disease mortality as well as in all-cause mortality. So there was that signal of benefit with glycoside-based treatment in the ADVANCE trial. And one of the possible hypotheses was the excess risk for severe hypoglycemia in the ACCORD trial compared to the relatively lower risk for hypoglycemia in the ADVANCE trial. So just a short review, we're quite familiar with the ADVANCE, that is the Action in Diabetes and Vascular Disease, Pretorax and Diamicron Modified Release Controlled Evaluation. This is looking at intensive blood glucose control and vascular outcomes in patients with type 2 diabetes. So these 11,000 type 2 diabetic patients were randomized into 2 groups, an intensive glucose control group, which primarily used gliclazide MR plus other drugs to require an HbA1c of less than 6.5%. Versus a standard glucose control whereby anti-diabetic drugs except gliclazide with target HbA1c that are defined on the basis of local guidelines. Composites of major macrovascular events that included death from CV causes, non-fatal MR or non-fatal stroke, as well as major microvascular events, particularly nephropathy or retinopathy, were assessed. So if you look at the HbA1c targets and differences, you see a divergence in the eventual HbA1c control of those patients in the standard versus those of the intensive control. Remember, in the intensive control group, the patients were given gliclazide MR plus other drugs as required to achieve a glycated hemoglobin value of 6.5% or no. Okay, so as you can see, they were able to reach that particular target in the ADVANCE trial. When you look at the combined major and macrovascular endpoints, you will see again the divergence in the line, which turned out to be significant with regards to the combined major macro and microvascular events. Okay, but the main driver for the benefit in the combined micro and macrovascular endpoints is basically the reduction in major microvascular events, as you can see in the graph on the right. Okay, a hazard ratio of 0.86% compared to the non-significant 0.94 hazard ratio for major macrovascular events. So that the benefit in major microvascular events in the ADVANCE trial were primarily a reduction in the incidence of nephropathy. And in the follow-up trial, that is the ADVANCE on observational trial, we've also noted that with intensive glucose control, there was a significant cumulative benefit with respect to ESRD. Again, comparing those who were initially randomized to standard versus that of intensive control. So what we've learned in the ADVANCE and in the ADVANCE on trial, that a strategy of intensive glycemic control involving gliclazide MR and other drugs as required led to a significant relative reduction in the combined major and major macrovascular and microvascular events, primarily as a consequence of the relative reduction in nephropathy that leads to cumulative benefit with respect to end-stage renal disease. Okay, so in the ADVANCE trial, we saw that reduction, and with regards to microvascular complications, as we saw in the ADVANCE-ON trial, but again, no harm with regards to CVD and mortality. So what other trials shows us the benefit of a particular drug, and that is gliclazide MR. One of those trials is the STENO-2 trial, or the multifactorial intervention in cardiovascular disease in patients with type 2 diabetes. The objective of the STENO-2 study was to compare the effect of targeted intensified multifactorial intervention with that of conventional intervention for those patients with type 2 diabetes and microalbuminuria. So conventional versus intensive treatment, looking at cardiovascular endpoints as primary and secondary outcomes. So as you can see here, those patients in the intensive therapy were able to reach the tighter glycemic control, cholesterol targets, triglyceride targets, systolic blood pressure, and diastolic blood pressure. When we focus on control of blood sugar, we have to remember the regimen that was used in the STENO-2 trial, whereby patients who were obese were started on metformin. If they were uncontrolled, gliclazide was added. On the other hand, for those patients who were not obese, they were started on gliclazide, and eventually metformin was added. And if still uncontrolled, then insulin will be added. So in this particular study, there were no significant difference in hypoglycemia between conventional therapy and intensive therapy. And the outcome showed relative risk of progression of DM microvascular complications turned out to be very significant for those patients in the intensive therapy, as well as in the composite endpoints of cardiovascular outcomes showed benefit for the intensive therapy versus that of the conventional therapy. So that shows us that in the ACCORD, in the ADVANCE, okay, in the UKPDS, in the STENO-2 trial, that reduction in HbA1c is important. But the next question is, does the end justify the means? Is it important? We know that HbA1c targeting a low HbA1c is important, but does it matter what anti-diabetic regimen should you use? Should you use metformin, thiazolidine, DPP-4-SU, alpha-glucosidase, and SGLT2 inhibitor? So in these trials, with regards to comparing glycemic control, there is an important trial, and that is the PROACTIVE trial. The PROACTIVE trial is a secondary prevention trial of macrovascular endpoints, the objective of which was to ascertain whether pioglitazone reduces macrovascular morbidity and mortality in high-risk type 2 diabetic patients. So these are patients on background anti-diabetic regimen, randomized to pioglitazone initially at 15, then up-titrated to 45 milligrams daily, versus that of placebo, looking again at cardiovascular primary and secondary outcomes. For those patients randomized to pioglitazone, you see some differences with regards to the metabolic profile. Blood sugars were a lot lower, HDL was a lot better, and triglyceride concentration was better in the pioglitazone group versus that of the placebo. If you look at the primary endpoint, unfortunately, with regards to death from any cause, non-fatal MI, stroke, acute coronary syndrome, leg amputation, and coronary revascularization, there was no statistically significant reduction in these events for those patients randomized to pioglitazone versus that of placebo. However, for the secondary endpoint, which included macrovascular complications, it showed that pioglitazone reduced the composite of all-cause mortality, non-fatal MI, and stroke. So in reality, the PROACTIVE trial was actually the first CV outcome trial showing benefit with a particular agent, and that is pioglitazone. And that sort of carried another study, on the other hand, comparing the incidence of cardiovascular events for those patients on pioglitazone versus sulfonylurea. Now that we know that pioglitazone in the PROACTIVE trial showed some benefit, they now try to compare the long-term effects of pioglitazone versus sulfonylurea when given in addition to metformin on cardiovascular events with regards to this type 2 diabetic patients. So it is basically like the PROACTIVE trial, but now compared to SU versus that of placebo. And in the TOSCA trial, it showed that cardiovascular events was similar with SUs and pioglitazone as add-on to treatment to metformin. Okay, so the SUs that were used in the TOSCA trial included gliclazide 50% of the patient population with glimepiride at 48% and 2% with glibenclamide. So if you look at the relationship of intensive glucose control and vascular complications in type 2 diabetes, it goes without saying that intensive glucose lowering is still important, primarily for the reduction in microvascular disease. For those studies that shows benefit for the reduction in cardiovascular disease and CV mortality with regards to HbA1c reduction, we know that, for example, in the PROACTIVE in the TOSCA trial, there may be extraglycemic effects of glucose-lowering drugs, as we saw in the pioglitazone PROACTIVE and TOSCA trial. Okay, what also favors benefit, now, as we've learned in the UKPDS, that achieving intensive glycemic control for those patients who are newly diagnosed diabetic will turn out to be beneficial if you institute therapy early so that you'll get what you call the legacy effect. However, there are specific studies showing limited benefit if you do not address multifactorial intervention, as we saw in the STENO2 trial. There are agents that may be specifically harmful, like, for example, tolbutamide in the UDTP. And of course, the value of intensive glycemic control for those patients with long duration of diabetes may not be as much, as we've learned in the ACCORD, in the ADVANCE, as well as in the VADT, for the lack of benefit for CVD outcome. So we now go to this slide, and these are the CV outcome trials for type 2 diabetes. We know that because of these new agents in the CV outcome trial, the SUs are being eased out with regards to management of type 2 diabetes. But we have to remember that the designs of this trial. So this is, of course, the EMPA-REG trial. We've learned that for those patients randomized to EMPA at 25 and 10 milligrams versus placebo, we have to remember again that these patients were not just on these medications, but they were on background treatment, showed reduction in the MACE, in the major adverse cardiovascular events. So that included CV death, non-fatal MI, and non-fatal stroke. Significant reductions in those outcomes. Similarly, in the CANVAS trial, whereby patients were randomized to canagliflozin and placebo plus background anti-diabetic agent, we also see reduction in major endpoints. In the DECLARE trial, the same for those randomized on dapagliflozin 10 milligrams or placebo. Again, they were on background anti-diabetic regimen. We saw benefit with regards to cardiovascular death and hospitalization, okay, for those patients randomized to dapagliflozin versus that of placebo. And even in the CREDENCE trial, which is a primarily renal outcome trials for type 2 diabetes, we also saw benefit for those randomized to CANA versus that of placebo. But it's very important that we take note of the caveats with regards to interpretation of these trials, the EMPA-REG, the CANVAS, the DECLARE, and the CREDENCE trial. So first is one, that in this CV outcome trial, the patient populations differ. So again, in the EMPA-REG, 100% had established cardiovascular disease, while in the CANVAS, in the DECLARE, and in the CREDENCE trial, there were different fractions of patients with established cardiovascular disease. So not all patients have had events prior to enrollment in the trial. Very important also to take note that the baseline characteristics of these patients is that some or most of these patients were on background anti-diabetic regimen. So if you look at sulfonylurea, more than 40% of the EMPA-REG, CANVAS, and the DECLARE trial were on sulfonylurea, and even 30%, almost 30%, of those patients in the CREDENCE trial were on sulfonylurea. So that the benefit of SGLT2 inhibitors were primarily on secondary prevention, meaning for those patients with established cardiovascular disease. So across the different CV outcomes for MACE, for CV death, for MI, as well as for stroke, as you can see, the benefit for primary prevention is lacking in this SGLT2 inhibitor trials. So those are what we've learned in the RCTs. Unfortunately, in the RCTs, there are limited segment of the patient population But what we also learn is that with RWDs or real world evidence, that there could be a broader and more representative of the patient population, so that whatever data that we get from RCT should be complemented by real world evidence. And one of those real world evidence is the CVD Real Nordic, whereby they use real-world data from clinical practice comparing cardiovascular mortality and morbidity in patients using SGLT2 inhibitors versus your glucose-lowering agents. And as we saw, in the CV outcome trial, there were benefits for the use of SGLT2 inhibitor, as you can see in this forest plot, for cardiovascular mortality and major adverse cardiovascular events. But what is important in the subgroup analysis is that in those patients given SGLT2 inhibitor and already on sulfonylurea, you see that the benefit for cardiovascular mortality persisted. And that same is true for those patients already on SU, whereby SGLT2 inhibitors were added with regards to reduction in major adverse cardiovascular events. So that means that the benefit of SGLT2 inhibitor persisted even if they were combined with sulfonylurea. And this holds true in the CVD-REAL-2 trial. They had the same analysis with regards to interaction with other medications, now with broader cardiovascular outcomes, all-cause death, heart failure in acute coronary, and all-cause death, MI, and stroke. As you can see, these outcomes favor SGLT2 inhibitor. When they did analyze SGLT2 inhibitor together with sulfonylurea, again, it was very consistent that all of those outcomes turned out to be persistently beneficial, even together with a sulfonylurea. So to answer the question, do sulfonylurea still have a place in clinical practice, or has the sun set on sulfonylurea? So in June 7, 2019, so that's almost 2 years ago, the American Diabetes Association presented a very important study that somewhat gave a new lease in life for the sulfonylurea. This is the evolution of different therapies for type 2 diabetes, especially looking at sulfonylurea. We mentioned about the UGDP, the UKPDS, which showed no difference in MI or diabetes-related deaths with SUs versus sulfonylurea and insulin. In the ADOPT trial, there was no increase in CV events with glibenclamide versus rosiglitazone, which is a thiazolidine diode. And in the ADVANCE, we also saw no effect on CV events with gliclazide plus other glucose-lowering agents. And of course, we've learned about the TOSCA-8 study earlier. But in this American Diabetes Association convention, we've heard of the Carolina trial, and that is the cardiovascular outcome study of linagliptin, which is a DPP-4 inhibitor, versus glimepiride in patients with type 2 diabetes. So this is a very simple trial design whereby linagliptin was compared to glimepiride, which is a sulfonylurea, and particular CV outcomes, were included. These were the inclusion criteria for the Carolina study. So if you look at the HbA1c over time by treatment, you see no treatment difference with regards to glycosylated hemoglobin versus linagliptin and glimepiride. But what is important in the CV outcome trial was that there was no difference or non-inferiority of linagliptin with regards to glimepiride on the CV outcomes. That is 3-point MACE, time to cardiovascular death, time to all-cause mortality, and time to non-cardiovascular death. So they were similar with regards to the CV outcomes. There were differences in body weight over the treatment period, but what is important was the number or the occurrence of moderate or severe hypoglycemia over time by treatment. So I think it is very important to take note that among adults with relatively early type 2 diabetes and elevated CV risk, the use of linagliptin, which is a DPP-4 inhibitor, compared with glimepiride, resulted in non-inferiority of composite of cardiovascular outcomes. So in a new trial, in 2020, so this is a real-world evidence trial. On the other hand, comparing the effectiveness, so this is an efficacy analysis of gliclazide MR versus another DPP-4 inhibitor. In this case, this is sitagliptin, a second-line treatment for after metformin. This is again comparing these adult patients given gliclazide versus sitagliptin as second treatment after metformin. So they were matched using high-dimensional propensity score. Again, this is an effectiveness trial, so that HbA1c targets were the primary and secondary endpoints. So these data were collected from patient records, no, from the United Kingdom Clinical Practice Research Data Link. And this is the study design. As you can see, the index date were for new users of gliclazide MR or sitagliptin. They did a propensity score matching and observed for several years the HbA1c, durability of HbA1c reduction, and hypoglycemia for this group of patients. As you can see, they were matched, and the propensity matching showed similarities in the parameters or in the description of those patients on gliclazide MR and sitagliptin. So the results showed that with the rapid separation of curves that favored gliclazide MR, you will see that more patients on gliclazide MR have a higher probability of reaching target of less than 7%. So the darker line showed that there were more patients on gliclazide MR that will be reach an HbA1c target of less than 7%. 35% more likely to reach targets of HbA1c of less than 7 with gliclazide MR versus that of sitagliptin. The secondary endpoints of achieving HbA1c target of less than 6.5 was also seen more for gliclazide MR versus that of sitagliptin, and 11% more likely to reduce HbA1c by more than 1% with gliclazide versus that of sitagliptin. And this showed similarity with regards to durability as well as persistence. Again, no difference for your DPP-4 inhibitor versus your gliclazide. When they did subgroup analysis with regards to the primary outcome of HbA1c reduction, it was maintained, across subgroups of ethnicity from Southeast Asian and white Europeans, and there seems to be a larger effect of gliclazide MR versus sitagliptin in patients with baseline cardiovascular disease compared to those without. There was also no significant difference in hypoglycemic event. So this real-world evidence showed that a second-line treatment, gliclazide, was actually more effective than sitagliptin in reducing HbA1c. So with that being said, the CV outcome trial that we've learned from Carolina, as well as the real-world evidence with the UK database, can we now extrapolate the benefits of gliclazide over glimepiride in the light of these studies, especially the Carolina trial, with regards to CV mortality outcomes, weight, and hypoglycemia? So this is a retrospective analysis comparing occurrence of these outcomes: total death, CV death, MI, stroke, and cardiovascular death for those patients with no previous MI, those with primary prevention, and those with established MI. You will see that compared to metformin, which is perceived to be cardioprotective among the oral anti-diabetic drugs, you will see that it turned out to be not different to metformin with regards to the outcomes of total death, cardiovascular death, and even the composites of MI, stroke, and cardiovascular death, as it touches the line, just like your metformin, which is the reference drug for this particular analysis. So this study showed that with most SUs, patients are relatively low and high cardiovascular risk when compared to metformin. The risk associated with gliclazide and repaglinide was not statistically different from that of metformin. In a systematic review and network meta-analysis looking at mortality risk among sulfonylurea, you will see that among sulfonylurea compared to glibenclamide, there is lower risk compared to glibenclamide with gliclazide versus that of the other SUs, even compared to glimepiride, which was used in the Carolina trial. And more important to that is the GUIDE study, again comparing efficacy and safety. As you can see, when they compared gliclazide MR and glimepiride in type 2 diabetic patients, you see equal reduction in HbA1c as well as equal reduction in fasting plasma glucose. But what is important is that there were more patients free of hypoglycemia with gliclazide versus that of glimepiride. So it shows us that glimepiride and gliclazide are as efficacious with regards to HbA1c reduction, but you have more safety profile because of the less hypoglycemia with the same HbA1c reduction with gliclazide versus that of glimepiride. And we've learned that also in these two very important trials, again, comparing gliclazide with other SUs and sitagliptin with regards to safety profile of gliclazide when we measure hypoglycemia. So in this Carolina trial, we've learned that there was no difference in the incidence of CV events with glimepiride versus linagliptin. And if we now compare those studies that I've mentioned with regards to glimepiride and gliclazide, we now can extrapolate the benefit of gliclazide versus that of glimepiride. So what is now the recommendations with regards to SUs in the prevention of type 2 diabetes complications? The IDF came up with the 2017 recommendation for primary care in that metformin is the preferred choice, and the second glucose-lowering drug as added to metformin at best should be a sulfonylurea, a DPP-4 inhibitor, or an SGLT2 inhibitor. There are also guidance-specific recommendations, particularly talking about gliclazide, as a preferred SU for both the South Asian Federation of Endocrine Societies, Australian guidelines, Canadian guidelines, the WHO, and even the Primary Care Diabetes Europe, showing preference of gliclazide versus all other SUs for these recommendations. And of course, we're well aware of this most recent ADA-ESD recommendations, whereby first-line treatment is still metformin together with lifestyle intervention. And for those patients with high indicators of cardiovascular disease or established ASCVD, that GLP-1 receptor agonists and SGLT2 inhibitors be considered. So that if we apply this concept in our two patients, the one with newly diagnosed diabetes versus the one with established cardiovascular disease, we have to remember that the recommendation point mostly for the use of SGLT2 inhibitors as well as GLP-1 receptor agonists. We have to remember that the patient population with established cardiovascular disease in the CV outcome trials were just a small portion of the diabetes population. So just to illustrate, if we see this illustration, you will see that these are the total diabetic population. The benefit for the SGLT2 inhibitor, particularly for the DECLARE, was this much, because only 40% of those enrolled or only 60% of those patients in the DECLARE trial had multiple risk factors. So 34% will benefit, or this much will benefit with regards to the patient population characteristic in the canvas, and this much because 100% or 99% of those patients enrolled in the EMPA-REG trial with that established cardiovascular disease. So is there really a paradigm shift in the daily practice of our for management of diabetes? So the answer is yes, particularly for this patient population. For our lawyer, I do agree that he should be started on either a GLP-1 receptor agonist and an SGLT2 inhibitor. But again, that will just be a small fraction of our patient diabetes population. But for most of our patients with diabetes without established cardiovascular disease, I think it is really applicable to individualize eventual treatment. So it means that not all patients should be on an SGLT2 or a GLP-1 receptor agonist, because we can consider for this patient uncontrolled with metformin as sulfonylurea, like gliclazide MR. So in conclusion, hopefully I was able to show you complications that we get with elevations of HbA1c, the value of lowering glycemia, and based on current diabetes guidelines, the use of sulfonylurea with potent HbA1c reduction, good hypoglycemic profile, and CV safety like your gliclazide is still a valuable option in reducing both macro and microvascular complications in diabetes. And going back to the Carolina, we saw no difference in comparing glimepiride with linagliptin, an SU, and the DPP-4 inhibitor with regards to CV events. So it's very noteworthy to hear from the primary author of Carolina, and that is Julio Rosenstock, wherein he said that we think we've vindicated sulfonylurea, at least glimepiride specifically. Debate will come whether or not we can generalize this to other sulfonylureas. Most likely, yes, but we can't say with certainty. But if certainty eliminates the stigma that sulfonylureas had for more than 50 years. And that is, of course, because of the Carolina and glimepiride. But we have to remember that gliclazide is not available in the United States, so that their experience is lacking and they may not be aware of the additional benefit in the studies that I've shown you for gliclazide MR. So that is why, as a student of Carolina, may I say that our vast treatment experience with gliclazide, as well as the studies suggesting favorable CV and safety profiles of gliclazide, suggests that it is probably better than glimepiride or comparable at worst. So again, indulge me with this rumination. So again, that's my last slide. Thank you very much.
All right. Thank you once again, Dr. Bien Matawaran, for that very clear and insightful presentation on sulfonylureas as demonstrated by several real-world evidences and randomized control trials, and the benefits that our patients can get when they get this sulfonylureas, the gliclazide MR in particular. Sir, let me begin some questions for this open forum for some points for discussion. You opened the lecture on real-world evidences, citing your EC-DIA and your DIA Ramadan. And as we know, real-world evidences usually complements randomized controlled trials or vice versa. How do you think that the real-world evidences that used your gliclazide MR, the EC-DIA, your DIA Ramadan complements the ADVANCE and the ADVANCE-ON studies?
Okay, so the word, you actually hit it in the spot, and that is complement. So I think we've seen. I think in the EC-DIA trial, it's basically as a real world evidence on efficacy. Okay, so it showed how efficacious your gliclazide MR with regards to HbA1c reduction. And the DIA Ramadan is basically a real-world evidence study on safety, and that is the good hypoglycemia profile. And the ADVANCE in itself actually showed that. No, it showed that with a diamicron or a gliclazide MR-based therapy, so remember in the intensive arm, wherein they use gliclazide MR in the ADVANCE trial, they push the dose of gliclazide MR. And the top dose of gliclazide MR is 120 milligrams per day. And if still uncontrolled, they added another agent. So in the ADVANCE trial, it showed also the efficacy of the agent, because 70% of those patients in the ADVANCE trial were taking 120 milligrams of sulfonylurea, and yet, going back to safety, the hypoglycemia profile was very good, no, for the ADVANCE trial, especially if you compare that to the ACCORD and the VADT. So the ADVANCE trial as a randomized controlled trial showed both efficacy and safety of gliclazide MR, and that was highly complemented by the EC-DIA and the DIA Ramadan.
Okay, so thank you very much, sir. Synthesizing those real-world evidences and randomized control trials give us a very reassuring fact that using gliclazide MR is both safe and effective. Sir, the ADVANCE studies showed that intensive glucose control decreases your microvascular complications, but not much with regards to macrovascular complications. Although you've mentioned it in your presentation, I'd just like for you to highlight again, does intensive glucose control still matters in the light that you have this macrovascular benefit that our patients can experience with just 3 months of using this SGLT2 or probably a couple of months using this GLP-1 receptor agonist? Do you think it still matters?
Yeah, it still matters because again, remember that the trial design for the CV outcome trials and the older trials were a lot different. No, the ADVANCE, the VADT, and the ACCORD were comparison of intensive, meaning a higher or a lower HbA1c versus a higher HbA1c, whereby the CV outcome trials were supposed to be done to reach glycemic equipoise, meaning the two arms, the placebo and the intervention arm, should achieve both good glycemic control. So meaning a lower HbA1c. And that lower HbA1c is the benefit that you get from the previous trial. So to say that glycemic control is not important, then what could have been done, no? If you actually look at it, dapat hindi na lang pinababa yung yung HbA1c doon sa CV outcome trial. So bigyan mo ng placebo, bigyan mo ng SGLT2 inhibitor or GLP-1 receptor agonist and maintain them at HbA1c of 10%, for example, or 9%. Will there be reduction? I don't think so. So that's how I look at the outcome trial. You cannot take away HbA1c reduction, no, from the CV outcome trial, because remember, those interventions should lower HbA1c to eventually find out if there's additional benefit for the molecule itself. Kaya parang unfair to say that glycemic control is not important anymore, because in the CV outcome trial, sugars went down. Okay? So kung hindi mo siya pinababa and yet hindi sila nag-MI, hindi sila nag-stroke, as well as hindi sila nag-CV death, then baka nga. But again, HbA1cs went down to target 7% and below. Kaya HbA1c reduction is still important.
Okay, so that's why for us endocrinologists, the center of our plate would always be glycemic control, and that equates to HbA1c reduction. Coming from that line, sir, if we are to write Unite 2 as Philippine guidelines for managing diabetes, would SUs stand a chance?
Yes. Okay, the confident answer is yes. And I think, as I also made a point, that analysis of the WHO, we have to still consider cost. Okay, I particularly see patients of different social strata. So, ikaw, JR, puro mayayaman pasyente mo.
Ano, hindi.
So, as you know, I practice in both UST Hospital, which is a private teaching hospital, and also go to Jose Reyes Memorial Medical Center, which is a government hospital. So, I can basically see the end-to-end spectrum of patient population with regards to giving insulin as well as to giving oral agents. Okay, if my patient can afford, for example, an SGLT2 inhibitor, and there is indication for SGLT2 inhibitor, then I would give it, no, particularly for patients who can afford it. But for example, if you give an SGLT2 inhibitor which is a bit costly, and then you cannot maintain the agent for quite some time, then the patient will be uncontrolled. Okay? So, andun pa rin yung value ng HbA1c. Okay? Ibig sabihin, I would rather give him an SU, metformin, that he can maintain for quite some time, for a long duration of time, whereby his HbA1c will be at target, then give him, for example, even if he has established cardiovascular disease, bigyan ko siya ng SGLT2 inhibitor, mabibili niya for 1 week, and then hindi na siya mag-follow up sa'yo kasi napahiya siya na hindi niya na kaya bumili ng gamot. So babalik siya sa'yo, sure, kahit na nagbigay ka ng SGLT2 inhibitor with an MI or with a stroke, because you were not able to reach glycemic target. So cost will be very important. No? Unless we tell ourselves, unless we do not admit that we are a low resource country, then we will just be pushing these agents without really thinking at cost, no? Because importante pa rin. So, but if cost is not, is not a factor, then I agree that go with the newer agents that shows benefit for CV outcome trial. Pero most likely in the Unite 2, JR, ikaw yung nandun eh. So, I would suggest, ikaw na yun, hindi na ako yun eh. So, I would suggest, siguro for the recommendation, that the cost analysis be part of the recommendation to be it more realistic, di ba? Kasi, kailangan at least pababain mo yung HbA1c pa din.
I think the guideline has to be adapted to the local setting, sir. Just to wrap things up, sir, why glycoside MR? Why Diamicron?
Okay, so I think the evidence speaks for itself. Okay, for at least for the group of sulfonylurea, we are confident that we have the advanced trial in the advance-on showing again efficacy and safety of the agent with regards to the cardiovascular outcomes as well as the microvascular outcomes. It did not turn out to be harmful with regards to CV events, but it was safe, no? Good enough. Kumbaga, non-inferiority. Because sabi nga ni Rosenstock, for the past 50 years, the SUs have been maligned, di ba?
Yes, sir.
Na fake news, na pumangit ang reputation. But, and again, they are not familiar with glycoside. The Americans do not use glycoside. So that in itself, the advance and the advance-on trial just gives me confidence, no, in using the drug. And my personal experience with my humble use of the drug for my humble number of patients has shown that it is effective, at least as part of my armamentarium in treating hyperglycemia in patients with type 2 diabetes. So experience and the body of evidence showing benefit.
Okay. Maraming salamat, Professor Bien Matawaran. Thank you very much for your time and expertise on the matter at hand. Thank you for sharing that our time-tested, reliable, experience-based, experience-backed sulfonylureas, particularly your glycoside MR diamicron, is still a formidable, effective, and safe agent in the treatment of our patients with type 2 diabetes. Keep safe, and we hope that you'd enjoy the rest of convention. Mabuhay!